Tom, are you there? Tom may have stepped out for a minute. Okay, or he may be tied up working on something. So what we'll do is we'll go ahead and get started. Once again, if you have questions, I noticed that a lot of people are putting their questions in the question tab. If you would just kind of put it under the chat tab, and that way Tom can kind of monitor it in one location instead of having to go back and forth between two areas. That might be helpful for him. So let me just kind of basically start off by saying that, again, the pretest is not meant to intimidate you. Some people feel really good after taking the pretest. Others feel kind of bad, feel like they don't know as much as they thought that they knew. And either of those feelings are fine at this point in time, okay? Because basically what we're using that for is a way to give you some feedback on exactly where you are today, all right? So if you feel bad about it, don't feel bad about it. That's what the next several days is for, is to try to help redirect your focus on the things you need to be paying close attention to and learning if you haven't already done so, all right? So on page 13, we've already given you the answers there. The good news about this test is that we will be going over it, but we will be going over it by section. Okay, so whenever we finish, like this, you can see on the screen there, the next section we're going to be talking about is patient assessment. And so if whenever we finish patient assessment, then we're going to go back and answer those questions that relate to patient assessment. And they're actually in sequential order. By the way that we do them there. And you can see that in the answer key there. Okay, so all the questions on the pretest will be gone over and answered after we complete the section information and going over the information in that particular area. And what you'll find is after we've gone over the information, you'll look at the questions from that point, and some of the ones you were scratching your head about, you're going to say, oh, the answer is this, because you learned something that maybe you didn't know. All right. We also have given you several on page 14 and 15 in your study guide there. We've also given you a different way of doing an analysis. You can look at the questions based upon the style of questions, whether it was a recall, application, or analysis. And then we also give you the opportunity to do an analysis on the content, so that if you're trying to discover whether or not you're weak in something or not, you'll be able to do that based upon your scores for today. Okay. If you turn over to the next page there, where it says patient assessment section A, we're going to be starting there. And if you'll turn the page from that over to A3, page A3 in the study guide. There you see the content outline. These are the things that we're going to be going over in this particular section. We'll be talking about assessment of the patient, reviewing the patient records, bedside interview and medical history, physical exam of the patient, radiographic imaging, other imaging procedures, special diagnostic studies, lab testing, echocardiogram, assessment of the infant, and monitoring data. And what you're going to find is we're going to spend most of today, pretty much all of today, going over this information. It's a lot of stuff to cover. But again, the thing that you're going to be able to see is that if you're good at patient assessment, then you're going to be good at figuring out what's wrong. If you have a hard time figuring out what's wrong, that means that you're weak in patient assessment. All right. So we're going to be going through and identifying the things that are important for you to learn and to know for this exam. All right. Now, let's talk a little bit about your study guide and how it's developed. This study guide literally comes from, if you look at the slide, this is a picture or a graphic of the therapist multiple choice exam detailed content outline. This is just one little small example of what you can actually go to the MBRC website and download this and look at all the information that could potentially be asked on the test. All right. So that's what we do. To make your study guide or to develop your study guide, we go to this outline and then we develop our study materials based upon what the MBRC says may be on the test. Now you notice over here that they tell you how many questions in this area are going to be recall, how many are going to be application, how many are going to be analysis. All right. And based upon the number of questions in a particular area, like you can see here under evaluate patient or evaluate data in the patient record, there could be 4 recall questions and 6 application questions. So based upon the number of questions in here, this is how we recognize or identify how important this information is, or because it represents a certain percentage of the test. All right. So what we have done is we've gone through and developed our study guide based upon this matrix. And so if by chance there is, we don't know what's going to be on the test in terms of, actual questions, but we know the style of questions because the MBRC has a public record of that, the type of questions or the style of their questions. And then we also know how they construct their questions. So we take those things into account. And then we take this matrix and this is what we produce our study guide from. All right. So really what you've got in front of you there is the MBRC test matrix that is basically completed for you. And what we've done is we've not just reproduced what's here, we've taken what's in here and added to it more information about those concepts. All right. So what we will be doing over the next 3 days is going through this and identifying with your highlighter the things that are important for you to know and to learn in preparation for this test. All right. And so as we go through things, some things need very little explanation. Just here, this is information you need to know. So you'll just highlight it. I'll just say highlight this. Other things may need more explanation. And when I give you more explanation, then we'll talk about that. But here's the thing I want to make sure everybody understands is that everything that's on the slides, okay, is actually in your study guide. So you don't have to worry about trying to take information off of the slide and put it into your study guide. I will be talking from the study guide and we'll be using the slides to kind of keep us on track with where we're at. All right. If there's ever a time where I need you to add something to your study guide, I will pause and I will tell you, please add this in. All right. Or if there's ever a slide that is not in your study guide, what I will do is I will pause and say, here, take a screenshot of this. All right. So you can either do that with your phone, or if you just want to do a screenshot off of your computer, however you want to do that. Okay. So there's not a lot of those opportunities out there, but there will be some. All right. So the main thing I want you to understand is everything, all of my slides, some people always, the first thing they start thinking about, can I get a copy of his slides? No, you can't get a copy of my slides because my slides are your study guide. You've already got a copy of them. All right. And then any slides that I use as supplemental material, you will get an opportunity to take a picture of that from a screenshot, and I will identify that for you so that you know there's no question, hey, should I take a picture of this or not? All right. So so as we go through this, I'll be kind of pointing you to the things that I want you to highlight and talking about the things that are very important. Okay. And if I stay on a particular subject matter for a long period of time, and I usually identify it, I'll usually say this is very important. I mean, that's just how I am. I'm kind of one of those black and white people. I like somebody to tell me exactly what it is that's important. And, do I need to listen to this or not? Okay. And so that's going to be how I kind of roll through some of this information. All righty. So let's go to page A4. And let's start off by talking about the first thing, patient assessment. that we want to make sure that you know is this concept about life functions. So highlight letter A there on page A, top of page A4, life functions. Now, let me just say this, because again, if you want our highlighter to last for the entire seminar, if you're one of those people that highlights the entire sentence when I say highlight letter A, you're going to run out of highlighters. So you're going to need to make sure you have some other highlighters available. All right. If you just highlight the letter A, which is what I encourage you to do, when I say highlight letter A, then you're going to have plenty of highlighter left to do the entire study guide. All right. So I'm just, you can do it however you want to. I mean, some people like to, to highlight everything. I think it gets too distracting if you highlight everything on the in a particular sentence instead of just the bullet point at the beginning, like the letter A or the number 1 or something like that. But I leave that to your discretion. Okay. So life functions, this is a very important concept. Again, this is our goal as a respiratory therapist, is to make sure that we get oxygen from the air and that it gets into the cells of the body so that they can use it to do their, specific function and task. All right. So the 4 life functions are on this slide here, letter B, and I want you to highlight all 4 of these. All right. 4 critical life functions. First off, there's ventilation. That's the first one. The second one there is oxygenation. The third one is circulation, and the fourth one is perfusion. And over to the left-hand side of this list, I want you to write this statement for me. Order of priority, order of priority. All right? And what we're saying here is that these are listed in the order of priority. So on this entire test, we're always going to hear us refer back to our life functions. And what we're saying here is that if we've got a problem with the patient and the problem is between ventilation and oxygenation, we're going to fix ventilation first if we're only given a choice to choose one answer. All right. If we have a choice between ventilation and perfusion, then we're going to do ventilation first on the question and not worry about perfusion on that particular question. So basically, the first thing that we want to fix as far as a patient problem is any problems with ventilation. We want to identify those and fix them. Then after ventilation, we want to identify any oxygenation problems, fix those. Then we want to identify any circulation problems and fix those. And then we want to identify any perfusion problems. All right, so those are the 4 life functions. All right. Highlight letter C there where it says, how do we measure these 4 life functions? This is how we measure them. Highlight number 1 there. We evaluate ventilation by looking at respiratory rate, tidal volume, chest movement, breath sounds, P-little CO2, and end-tidal CO2. All right. That's how we know if somebody's ventilating. How do we know if somebody is oxygenating? Well, we look at their heart rate, we look at their color, we look at their sensorium, the P-little-AO2 and the SpO2. So highlight number 2 there. Highlight number 3, circulation. How do we evaluate it? We look at heart rate and strength and cardiac output. Okay. And then number 4, highlight that one. How do we evaluate perfusion? We do blood pressure, sensorium, temperature, urine output, and hemodynamics. All right. So those are all the ways that we evaluate these 4 life functions. Now, on the left-hand side of letter C there, I want you to write this statement for me. All right. The statement says emergency if a severe problem. So if I have a severe problem with any one of these 4 life functions, that is going to be classified or constitute an emergency situation. But it has to be a severe problem with one of these 4 things. Okay, one of these 4 life functions. So anytime we say in this seminar, well, this is an emergency. Well, why is it an emergency? And that means that something is severely wrong with one of the 4 life functions. And that's got to be fixed first. Okay, if it's a severe problem. Again, what is the order of priority? Because sometimes you're going to look at a blood gas and the CO2 looks bad and the oxygenation looks bad. Which one do I fix first? I always take care of ventilation first. That's always my first priority. All right. Then I look at oxygenation. Then I look at circulation. Then I look at perfusion. Okay. And in that order. All right. Drop down to the bottom of the page to letter D under number 5 there. It says when you have an emergency, number 1, it's just emphasizing what I just said. The first priority is ventilation. Number 2, the second priority is oxygenation. Number 3, the third priority is circulation. And number 4, the final fourth priority is perfusion. All right. And here's the other thing I want you to write on the left-hand side down at the bottom. All right. This statement. If you don't know what to do on the exam, ask about life functions. Ask about life functions. So on this test, at any point in time, if they give me a ton of information and I'm looking at all that stuff and I'm scratching my head, I said, I have no clue what's going on here. You know what I do? I do what Kettering taught me. I look at ventilation first. How's that doing? Are they ventilating okay? All right, yeah, they're ventilating fine. Then I go to oxygenation. How are they oxygenating? They're oxygenating fine. Okay, great. How are they circulating? Oh, man, circulation is not so good. Well, then that's what the thing that I need to fix. That's what's wrong. Okay. And so by going down through each one of these in the order of priority and evaluating it, that's going to be your best way to assess your patient. All right. And that's the way we want you to do it on this test. Because oftentimes on this test, there's going to be 2 problems. All right. Or there may be 2 answers. All right, that they give you, because there's 2 things that you see wrong. And you've got to figure out which one should be done first. If you want to know what needs to be done first on this test, always think about life functions. That will direct you and guide you in your decision-making process. All right. So make sure you do that. Top of page 5, reviewing the patient's medical record. What we're going to be doing in the medical record on this test is we're going to be looking for things that are abnormal, because things that are abnormal tell us that that's what the problem is. That's what's wrong. If there's nothing abnormal, then that means there's nothing wrong. So abnormal information in the patient's record is again going to dictate to us or help us identify what's wrong with the patient. So under letter A there, chart review, these are some things I want you to highlight. I want you to highlight number 1, we would look at admission notes. Number 2, signs and symptoms. Number 3, occupation employment history. Number 4, allergies or allergic reactions. Excuse me. Number 5, prior surgery, illness or injury. Number 6, vital signs. Number 7, physical exam. Under number 8, tobacco use. And under tobacco use, I want you to highlight letter A, pack years. That formula for pack years, which is pack years is equal to the number of packs per day times the number of years smoked. Okay, highlight that. You may have to calculate that on the test. The other thing I want you to remember about number 8, as far as tobacco use, is highlight letter D. You want to recommend nicotine replacement therapy, because again, if they are having issues with tobacco use, we want to try to help them get off tobacco. All right, so that's why you're going to recommend nicotine replacement therapy. Highlight number 9, advanced directives. You can kind of read down through those. Top of page 6, A6. The types of advanced directives, highlight number 1, the DNR, most of us know what that is. Number 2, the DNI, most of us know what that is. But again, those are terms that you need to be familiar with. So if you're not familiar with them, make sure you learn those. Highlight letter B, respiratory care orders. Highlight letter C, patient progress notes. You can just kind of read down through those at your convenience later. Letter D, patient laboratory reports. Letter E, top of page 7, A7, letter E, to intake and output. Highlight number 1. This is very important. Normal urine output is about 40 mils per hour, approximately 1 liter per day. Highlight number 4. If the intake exceeds the output, this could result in the following. You could get weight gain, you could get electrolyte imbalance, increased hemodynamic pressures, and decreased lung compliance. Highlight letter F, fluid balance. Changes in the central venous pressure can indicate changes in fluid balance. Well, what normal central venous pressure should we be looking for? Letter A, highlight that one. Normal CVP is between 2 to 6 millimeters of mercury. Highlight letter B. If we have a decreased CVP, then that means we're going to have a reduction in fluid volume. So hypovolemia could indicate hypovolemia, and we need to recommend giving fluid back to the patient. All right. Letter C, if we have an increased CVP, that can indicate hypervolemia. And if we have a situation with hypervolemia, then we're going to recommend diuretics. And the diuretic that we're going to recommend is what? And I can just hear you saying it in your mind, Lasix, right? Well, that's the one word that you probably will not see on this test is Lasix. They will use the word furosemide, and that's spelled F-U-R-O-S-E-M-I-D-E, furosemide. So that's the generic name for Lasix. So for this seminar, we're not going to use the term Lasix. We're going to use the term furosemide because that's what the MBRC uses, and we want to be talking their language and learning to speak their language for the next several days so we know what to anticipate, how they're going to say things. All right? Because I'm telling you, that's one of the biggest challenges on this test is being able to understand their terminology. All right? That's a big thing. So here again, if we got somebody, letter C, if we got somebody with an increased CVP, then we're going to recommend a diuretic, and the diuretic is going to be furosemide. Well, how much are you going to give? And I can hear a variety of answers coming through, but the answer is for this test is, I don't know. Who cares? Okay, the actual dosage is not the most important thing on this test. So you don't have to know dosages for this test for furosemide. There's only 2 drugs that you have to know dosages for on this test. That's oxygen, and we'll talk about that later, and albuterol. Okay, those are the only 2 that you need to know. Okay, 2.25 of albuterol. That's all you need to know. And some of you probably are breathing a sigh of relief right now. And yeah, I get that. I understand why you're breathing a sigh of relief, because I felt the same way. So how am I going to know how much? Because they will probably ask you, what should you should you give more or should you give less furosemide for this particular patient? Well, how are you going to know whether you should give more or less? I got to look at the CVP. If my CVP is greater than 6, then I need to give more. All right. If my CVP is less than 2, then I need to give less. If my CVP is somewhere between 2 and 6 millimeters of mercury, then I've given enough. So that's how you're going to know how much to give. It won't be a specific or an exact amount. It's just based upon, should you give more, should I give less, based upon the CVP. All right. The other thing you need to know about pharmacology in this seminar, this is how we will do pharmacology throughout the seminar. We don't do a whole section on just drugs. We have an appendix in the back that you can refer to, and we'll show you how to use that on day 3. But the drugs, we will be talking about them in situations in which you would use them. So it's kind of like, we're applying the use of these drugs as we use, because that's basically how it's going to be on the test. On the test, they're going to say, hey, this patient's got this problem. What would you recommend? Well, there's a drug that treats that. This is what I would give them. Again, you don't have to know the dosage. You just have to know what the drug is and when you would give it. All right. Top of page 8. The bedside interview and medical history. Under letter A there, highlight number 1, determining the level of consciousness. And you want to highlight letters A through F there. And next to letter A there, I want you to write the word good on the left-hand side. And then next to the letter F at the bottom, I want you to write the word bad. and draw an arrow from the top, from letter A all the way down to letter F. So here again, we've got an order of priority or an order of going from good to bad. So if a person is alert and responsive, that's good. Letter F, if they're in a coma, that's not good. All right. I also want to direct you to letter E, the word obtunded. If you're not familiar with that, make sure you know what that word means. It's a drowsy state. They could have a decreased cough or gag reflex and a risk of aspiration. And so we want to make sure if we have a patient that's obtunded, we need to remember that they can't protect their airway. So we need to provide an airway for them. All right, that's very important for us to remember about that word. What does it mean? And what is my action should be? I need to give them an airway. All right, if they're obtunded. Of course, the same thing would be true if they were in a coma. All right. Highlight number 2, check them for orientation to time, place, and person. You can read down through that. Number 3, assess the emotional state. You can read through that. Number 4, activities of daily living or ADLs. Most of you are familiar with some of those. The main thing I want you to remember about ADLs, you may want to write this phrase next to number 4, and that is we want you to evaluate when stable and ready for discharge. So you're going to evaluate your ADLs when the patient is stable and ready for discharge. So on the test, they may say, hey, you've got a patient who's in the intensive care unit that is unstable. Which of the following would you recommend? And if they offer you ADL, you don't want to pick that because, again, they're not stable, they're not ready for discharge, so that I don't need to be recommending an evaluation of that at this point in time. The only time I'm evaluating ADLs is whenever they are stable and ready for discharge. All right. Top of page 9, highlight number 5, measure subjective symptoms. Letter A, orthopnea. Anytime you hear this word orthopnea on this test, I want you to be thinking about letter A, not only the definition as far as the difficulty in breathing, but I want you to think about it being associated with those 3 letters at the end of the sentence there. And I would suggest you highlight them, CHF. So congestive heart failure. So if a person is having an orthopneic breathing pattern, then you need to be thinking they've got CHF. That's what's wrong with them. All right. Letter B, the words general malaise. All right. This is a way of describing a person who just kind of feels run down. There may be some nausea, weakness, and so forth. And usually that's associated with an electrolyte imbalance at the end of the sentence there. So highlight electrical imbalance. Remember, general malaise, what I like to call the whiners and complainers. If you got a patient who's whining and complaining, chances are they've got some sort of electrolyte imbalance, and that's what you need to give them, or to if they're low on potassium or low on sodium, give them those electrolytes to help perk them back up and make them start feeling better. Highlight letter C, dyspnea. And there are many ways that we can characterize dyspnea. And under number 1 there, we've got the different grades. There's 5 different grades of dyspnea you see listed there. And I would highlight letters A through E. Just remember that letter A, or grade 1, is less dyspnea. And grade 5 is more severe. So grade 1 dyspnea is not so bad. Grade 5 is really bad. All right. So they may give you that grading system of dyspnea on the test, and just that's how you would use that information to interpret it. Highlight letter D, pain. Under number 1 there, we need to note the location of the pain. B, the quality. What kind is it sharp or dull? C, the severity on a scale of 1 to 10. Again, 10 being bad, 1 being not so bad. Letter D, aggravating factors. E, relieving factors. Those are things we need to look at. Letter E, symptoms of the nose and throat. You can kind of read through those. Highlight number 6 towards the bottom of page 9 there, the respiratory care plan. And then highlight number 7, social support systems, number 8, physical environment, and then number 9, environmental exposures. And what I would suggest that you do between numbers 6 and 9, I would draw kind of a bracket or a brace or something. And then I will have you write this little statement off, that connects that bracket or brace. These are the elements of a discharge plan or a home care plan. So the respiratory care plan is part of the discharge plan. The social support systems is part of a discharge plan. The physical environment is part of a discharge plan, and environmental exposures. Those are all part of a discharge plan, okay? So those are things to keep in mind. If you're discharging a patient, they may offer those things to you, what should be evaluated, and you should pick any of those 4 items there. The respiratory care plan, the social support systems, physical environment, or environmental exposures. Under number 9 there, the big thing we're looking for as far as environmental exposures is letter A, any asthma triggers that may be at home, like pet danders or dust or things like that. Drop down to the bottom of page 9, highlight number 10. We're going to use proper interview techniques, and that's going to be letter A there. We're going to ask open-ended questions, not just yes or no questions. And we want to keep our conversation with them very simple. We don't want to use complicated or high technical terms, even though that's what the NBRC uses on their exam. But talking to patients, we want to keep it simple. Top of page 10, number 11, assessing patient learning needs. Again, that's just some stuff you need to kind of read down through. Number 12, nutritional status. Kind of review that. I do have a formula that I want you to write next to the nutritional status. And this is what the formula is. It's carbs equal an increased CO2. Carbs equal an increased CO2. So anytime you think about nutritional status, just remember that if you have a high carbohydrate diet, that's going to increase the amount of CO2 that's produced. And so you need to be very careful, especially in weaning situations, so that you're not adding to the work of breathing by increasing the person's CO2 load by loading them up with carbs, okay? So just kind of keep that in mind. So I think you kind of see the flow of things as we're going through this. You know, some things I'm going to just have you highlight, and then you'll come back and read later. And then other things I have you highlight, I'm going to give you some more explanation and maybe add some extra things to it. So that's going to be kind of how this thing's going to flow for the next 3 days, all right? Drop down the bottom of page 10, A10, highlight number 13, exercise tolerance, and highlight letters A and B. You need to ask them about how they do as far as walking, climbing stairs. And letter B, if there's any changes that could indicate an acute problem or worsening a chronic problem. Letter B, patient and family history. If you go to the top of page, well, you can read down through those. Go to the top of page 11, we're going to shift gears into a new area, which is called physical exam. So there are actually 4 parts to physical exam. If you want to, you can kind of list these at the top right-hand corner if you want: inspection, palpation, percussion, auscultation. We're going to talk about each of these individually as we work through the next several pages. But I want to just pause here for a second just to kind of prime your thinking a little bit before you take this test, to remember that in this exam, the NBRC expects you to be able to do all 4 of these in terms of assessing your patient. All 4 of these are important, okay? And so inspection, this is of course what we see. This is oftentimes what, I mean, you know, when you walk in the patient's room and look at them, that's kind of what you're doing. You kind of size them up, seeing what's going on. So most of the time we do this one, pretty regular as a respiratory therapist. Palpation, we may do a little bit like palpating the pulse, but actually palpating the chest, most of us don't go through that step in our assessment. However, on the exam, they oftentimes give you information related to palpation that can give you some clues on what the correct answer is. So pay close attention to that. We'll talk more about that here in just a minute. Same thing with percussion. Most of us don't do diagnostic percussion. We do therapeutic percussion, where we beat on the chest, so to speak, but we don't do diagnostic where we're patting the chest to see if it's dull or hyperresonant. Again, this is oftentimes information that they will give you on this test that will direct you the direction you should go as far as your answer. And so you got to be very careful at looking at palpation information and percussion information when they give that to you on the test. Don't just jump over it because you're like, well, I never do that. On this test, if you see palpation or percussion, you need to pause and read that information and assess it carefully about what it means, because oftentimes these two things right here are going to be the thing that points you in the direction you need to be going with your answer. All right. Now, auscultation, listening to breath sounds, all of us do that on a regular basis, so that's usually not an issue. But again, I just wanted to caution you on the front end of this section to pay close attention to palpation and percussion. All right. Anytime you see that information shared on the exam, look at it carefully and do a thorough evaluation of what it means, because again, that's probably going to point you in the direction they want you to go as far as your answer. All right. Okay, so we're going to take each one of these. First one there at the top, page 11, letter A, assessment by inspection. This is what you can see. We've already mentioned that. Highlight number 1, the general appearance. Those are things, age, height, and weight, nourishment. Those are all important things to look at. Number 2, edema. This is very important. Under letter A, peripheral edema, we want to highlight number 3. If we have peripheral edema, that could be caused by congestive heart failure and or renal failure. Okay. And we're going to do number 5. We're going to recommend diuretic therapy. What diuretic are we going to use? We're going to recommend, that's right, furosemide. Okay. So anytime we want to do diuretic therapy, we're looking at furosemide as far as our answer. All right. Highlight number 3, clubbing of the fingers is caused by chronic hypoxemia. Presence of this can be suggestive of pulmonary disease. Give you an illustration of what clubbing looks like. Number 4, venous distension. Here again, letter A, this occurs with congestive heart failure. So if you see that, think of CHF. Number 5, capillary refill. And highlight that one. That's an indication of peripheral circulation. Now let me pause here for just a second. Most of us, if they offered us information about capillary refill, we probably wouldn't even think about looking at that. All right. But on this test, remember, one of the things that we said about our 4 life functions, one of the most important ones is number 3 there, which is circulation. How do we evaluate circulation? Well, we told you you would be looking at capillary refill technique. Okay. And so what we should be understanding is that when we touch somebody's skin, it should blanch out and the color should return to that skin within 3 seconds. That's how we know that we've got normal capillary refill, and it's telling us something about circulation. So once again, on this test, if they ever offer you the option of looking at capillary refill, pay close attention to it, because they're telling you something about a life function. I know we don't typically do that in our jobs, but again, for this test, those 2 words, capillary refill, always stop and look at it. All right, and make sure that it's less than 3 seconds. All right, if it takes more than 3 seconds for it to pink back up, then that means you've got compromised circulation, and that is a life function, and that's something that needs to be corrected. All right. Number 6, diaphoresis. Drop down to letter E there, tuberculosis. It can be associated with night sweats, which again is associated with diaphoresis. And again, you're going to recommend anti-TB drugs. So that's something to keep in mind. Top of page 12, number 7, skin color. Couple of skin colors I want to zero in on here are letter D, erythema. That is redness of the skin. And again, that could be caused by capillary congestion from either inflammation or infection. That would be good to know. And then letter E, cyanosis. Again, this is an indication of hypoxia, lack of oxygen in the cells. So those are 2 important terms that we need to make sure we know what those mean on this test. Number 8, this is new on the exam. Remember, every 5 years, the MBRC updates their exam to put new content on there. And this is some new content that they've added to the new exam for 2020. And number 8 there, skin integrity. You want to make sure that we evaluate them for the appearance of the skin, pressure sores or ulcers, or evaluate any skin around the tracheostomy stoma site. Make sure there's no inflammation and sites of infection taking place in those areas. Number 9, chest configuration. I want you to drop down to letter D at the bottom of page 12 and highlight the words, letter D there, kyphosis. You need to be familiar with that term. That's a convex curvature of the spine. So it's an anterior posterior curvature of the spine, so kind of like the Hunchback of Notre Dame. Top of page 13, highlight letter E there, scoliosis. Again, that is a lateral curvature of the spine. You need to be familiar with that term. It's kind of easy to remember because it's kind of shaped like an S, and so that's where the term scoliosis kind of comes from. Or you could have letter F, a combination of those two conditions, kyphoscoliosis, scoliosis, all right? This is particularly significant because it can create a restrictive pattern and make it more difficult for the person to take deep breaths. So they would typically on pulmonary functions, they'll have reduced lung volumes. Letter G, the barrel chest. Most of us associate that, of course, with air trapping. Number 1 there, highlight that, COPD. If we have an increased AP diameter, that's kind of another way of saying they've got a barrel chest. So be familiar with those terms. Let's turn to page 14. Top of page 14 there. Number 10, movement of the chest or diaphragm. Couple of terms, letter A, symmetrical. That is a good term when you see both sides of the chest moving equal distance. And then highlight letter C, unequal or asymmetrical, the term asymmetrical. That's an important term to note. You need to know that it could indicate some potential pathology or disease because both sides of the chest are not moving the same. All right, symmetry is good, asymmetrical is bad. All right, drop down to number 11, breathing patterns. Highlight letter A there, term eupnea. This is one you want to pay close attention to because, again, on this exam, they won't say the person has a normal breathing pattern. What they will say is the patient has a eupnic breathing pattern. And some of you would say, well, why would they do that? Because they want to know if you can walk the walk and talk the talk as a therapist. So just remember, eupnea means normal. So if they tell you they've got a eupnic breathing pattern, then, oh, there's nothing wrong with them. That's good, right? Most of us are familiar with letter B, tachypnea. Letter C, bradynia. But highlight the words in parentheses there, oligonia. That's another way of saying bradynia, all right? Oligonia and bradynia mean the same thing. Once again, I'm kind of slowing down a little bit on these terms because these terms are how they speak to you on the test. So you've got to know terminology in order to be able to interpret what they're telling you, all right? Letter D, apnea, most of us know what that is. Letter E, hyperpnea, most of us know what that is. Letter F, Cheyne-Stokes, most of us have heard of that. Letter G, Biot's breathing, most of us have heard of that. Just remember that the Biot's breathing could be an indication of, some sort of CNS problem. And then letter H, Kussmaul's breathing. Again, this is a very fast breathing with deep breaths. Irregular in rhythm, usually is associated with hyperventilation, okay? And so because it's associated with hyperventilation and usually diabetic ketoacidosis, there's a couple things I want to add in here for you to remember when you think about hyperventilation, okay? So I want you to write this phrase down for me. Next to Kussmaul's breathing. Hyperventilation, semicolon, RO. You remember what RO means? RO means rule out. So RO, rule out decreased P little AO2, then metabolic. I'll interpret this for you here in just a second, okay? So this is how it should read. Hyperventilation, semicolon, rule out, decreased PaO2, then metabolic. So anytime on this test that you see the patient that is exhibiting hyperventilation by, looking at a blood gas or just, and seeing they have a reduction in CO2, the first thing you're going to want to do is you're going to want to rule out, do they have a decreased PaO2? Because if they have a decreased PaO2, the first thing you're going to want to do is give them oxygen. All right? Now, if they're hyperventilating and their PaO2 is fine, then hypoxemia is not what's causing them to breathe fast. What's causing them to probably breathe fast is a metabolic problem, like diabetic ketoacidosis, possibly. All right, so that's what we're saying here. If they're hyperventilating, rule out oxygen or reduction in PaO2 first. If that's okay, then the problem is a metabolic problem, and you need to fix the metabolic problem. Okay. All right, that brings us over to the top of page 15. Number 12, accessory muscle activity. Most of us know if they're using accessory muscles, then that's an indication for respiratory distress. 13, muscle condition. Know those two words there, hypertrophy and atrophy. And then highlight number 14. Oops, got ahead of myself here. Highlight number 14 and 15, retractions and nasal flaring. Those are two indications of respiratory distress. All right, two indications of respiratory distress. All right. Drop down to number 16, the character of cough. You can kind of read through that. 17, assessment of the patency of the airway. You're going to look at signs and changes of upper airway problems. And then the top of page 16, we've got some new information that is on the test, and that is the Mallampati classification. So you need to be familiar with the Mallampati classification. And as you can see here, it involves looking inside the person's mouth and having them stick their tongue out. All right. Highlight letter B there. There's 4 classes. There's class 1, 2, 3, and 4. And as you can see, as you look in the illustration here on the slide, you see less and less structures in the back of the throat as you go through each one of these, okay? So the big take-home message about the Mallampati score is number 5, that these, if they have obstruction of the back of the throat, then that's going to complicate your ability to ventilate and intubate them, all right? And highlight number 6, so the interpretation of it is, if you have a class 3 or class 4, that's considered to be a difficult airway. And so if you have class 3 or class 4 Mallampati, then you need to reach for letter B, a fiber optic bronchoscope or a video assist device. That's what you need to be getting a hold of, okay? Drop down to the bottom of page 16 there, highlight letter D, the paradoxical pulse or pulsus paradoxus. Just remember that this could indicate severe air trapping, like in status asthmaticus. And I want you to circle at the bottom of page 16 the word under at the very bottom there, severe. Circle that word severe. Next to it, I want you to write, this is an emergency. This is an emergency. All right. So remember, anytime on this test, if you see the word severe, that means it's an emergency. So if you've got severe hyperventilation or severe hypoventilation, then that means that you've got an emergency, right? Or a severe compromise in blood pressure. That just kind of helps you remember how to be thinking about these things. And again, if you're thinking about an emergency, remember on this test, if I've got an emergency, I need to evaluate my 4 life functions. Once again, what are my 4 life functions? Ventilation, oxygenation, circulation, and perfusion, and in that order. Okay, that's how I'm going to fix the problems. Evaluate one. If it's okay, move to the next one. If it's okay, move to the next one. If the next one is poor, fix that one before I move to the next one. All right. Top of page 17, number 2 there, tracheal deviation. Highlight letter D there, causes of tracheal deviation. And we've given you a box there, okay? Now, in the box, what you need to know is, first off, in this study guide, everything in a box is important. So write that statement next to the box. Everything in a box is important. Right? So in this study guide, anytime you see a box, that's important stuff. Make sure that you don't just gloss over that when you're preparing for your test. Look at it, make sure you know it and understand it. All right? So here in this box, we've got 2 situations that can move the trachea. All right? We can have the trachea pulled to the abnormal side in the first column there, and it says, then a good example of that is pulmonary atelectasis. So atelectasis is going to pull towards the side where the problem is. So if you have atelectasis on your right side, that means the trachea is going to be pulled to the right side, right? The second column there says that it's going to be pushed to the normal side or away from pathology, like letter or number 2 there, the tension pneumothorax. If you've got a tension pneumothorax, that means that you're going to have the trachea is going to be pushed away from the side where the pneumo is on. So if you have a pneumo on the right, the trachea is going to be pushed to the left side in that situation. All right. So make sure you know what how to interpret tracheal deviation. Pay close attention to it, because a lot of times people just say, oh, a deviated or trachea is pushed to one side. They immediately start thinking tension pneumothorax, and that may not be the case. Oh, great. Here, hang on a second. There we go. My computer's trying to do stuff it's not supposed to do. Sorry about that. All right. So highlight number 3 there, tactile fremitus. Drop down under letter B to number 3, bronchial fremitus. Make sure you're familiar with that term. And basically, bronchial fremitus is what we refer to as palpable bronchi. So you can actually feel the secretions vibrating. It's like, listening to breath sounds with your hand by touching the chest, right? And that just means they've got secretions in the airway that need to be cleared. All right, on page 19, let's see here. Get my slides caught up here, sorry. Letter C, assessment by percussion. Remember, we said this is a very important thing also. Palpation is important to look at, and percussion is important to look at, because it gives us some information that points us in the direction of the answer or the direction of the problem, as opposed to other things. Okay, so under letter C there, I want you to highlight number 4 on page 18. The following sounds are emitted. Highlight letter A, resonant. You need to know that the word resonant on a percussion note means that's normal. That's what we want to hear. Letter B and letter C, flat and dull, those 2 things mean the same thing. They mean less air, all right? So make sure you make a little note off to the left-hand side there. Maybe draw a bracket between flat and dull, and then just put less air next to them. That means the same thing. And again, if you drop down further to letters D and E, you can see here we've got them together, tympanic / hyperresonant. That means more air. So again, tympanic and hyperresonant, they mean the same thing, and they mean more air. Usually an indication of like a pneumo or something like that, okay? The flat or dull usually means that you've got like a pneumonia, all right? That brings us to the bottom of page 18, letter D, assessment by auscultation. Highlight number 1, normal breath sounds, vesicular. Once again, they're going to use this term vesicular if they say that the breath sounds are normal. You will never on this test see them say the breath sounds are normal. They will say they have vesicular breath sounds. And so you've got to know what that term means. Number 2, increased, decreased, or unequal or absent breath sounds. Highlight letter C, agophony. Excuse me. This is the patient is instructed to say E and it sounds like an A. And this would indicate consolidation in the lung tissue, like with a pneumonia-like condition. Top of page 19. Highlight number 3 there. Abnormal breath sounds, adventitious, letter A. Crackles, make sure you know that those are associated with secretions or fluid. Highlight number 1 under letter A, coarse crackles. Those are secretion problems in the large airway, and we can clear those with a cough. Or letter A, they may need to be suctioned or instruct them to cough. Number 2, medium crackles. Those are secretions in the middle airway. Letter A, we would recommend bronchial hygiene to fix that problem. Number 3, fine crackles or moist crepitant rails. That's secretions or fluid down in the alveoli. Letter A, it's often associated with CHF and pulmonary edema. And then letter B, the treatment for that, of course, would be oxygen, positive pressure therapy, positive inotropic agents. And let me give you a couple of drugs that you would use when we say positive inotropic agents. So examples of that would be digoxin and digitalis. And then digoxin is spelled Dogoxin, and digitalis is spelled Digitalis. All right, those are examples. Again, you don't have to know how much to give them. You just need to know those would be drugs that would be given in a CHF or pulmonary edema situation. And then, of course, diuretics, and we know the example of the diuretic is supposed to be furosemide. All right, that brings us to letter B there, wheeze. Highlight number 1, it's most commonly caused by bronchospasm. Number 2, recommend bronchodilator therapy for bilateral diffuse wheezing. Number 3, unilateral wheeze indicative of a foreign body obstruction. And again, if we have a unilateral wheeze, we would do letter A, recommend a rigid bronchoscope. We'll talk about that more later. Highlight letter C if we have a stridor, which is a high-pitched or crowing inspiratory sound. Highlight number 1 there, it can be caused by an upper airway obstruction. These are some examples of upper airway obstructions. Letter A, supraglottic swelling like epiglottitis, or subglottic swelling, letter B there, like croup or post-extubation croup. Letter C, foreign body aspiration, either solids or fluids. Those all could cause a upper airway obstruction. And then number 2, specific treatment for this is letter A, a topical decongestant such as racemic epinephrine. That's going to reduce the swelling and edema. Letter B, possibly suctioning or bronchoscopy for secretions and foreign body aspiration. And then letter C, intubation for severe swelling and epiglottitis. Now remember what we said the word severe means. The word severe means emergency. All right, so emergency, that means we've got to get an airway in place. So a couple of other words that are associated with severe that I'm going to kind of give you at this point in time, you may want to jot them down. You probably have heard the words or the terms mild, moderate, or marked, M-A-R-K-E-D, marked. Marked and severe mean the same thing. So make a note that marked and severe mean the same thing. So anytime you see that word marked, you need to think severe. Severe, that means emergency. All right. Bottom of page 19, letter D, stertor. This is something new that's on the exam. This is kind of the noisy breathing that occurs during inhalation. You can kind of read down through that. And then letter E, the pleural friction rub, is also something that may be mentioned on the exam. If you're not familiar with that, you can kind of read down through that as well. And it's typically associated with TB, pneumonia, those types of things. All right, top of page 20, heart sounds. Number 4 there, highlight letter A, normal heart sounds. Number 1, they're sounds created by closure of the heart valves. Number 2, the first heart sound is called S1. And then highlight number 3, the second sound is S2. And again, S1 is the sound that is lub-dub, lub-dub, lub-dub. All right? So lub or S1 means that you're having closure of the mitral and tricuspid valves. And we mentioned that to you there. The lub-dub, dub means that you're having the ventricles are relaxed and that the pulmonic and the aortic valves are closing. Those are the only 2 sounds that you need to remember for this test, S1 and S2. Because everything else that's not S1 and S2, that's considered not normal. So you may want to write that down next to the abnormal heart sounds. This statement, it says, anything that is more than S1 and S2, anything that is more than S1 and S2 is not normal. Get an ultrasound. All right? Anything that is more than S1 and S2 is not normal, get an ultrasound. And we kind of reemphasize that under number 7 there. All right? At the bottom, in the middle of page 20. So recommend echocardiogram. All right? Same thing as an ultrasound. All right? Number 5, we'll do this piece and then we will get my slides caught up here. Sorry about that. Number 5, blood pressure. So letter D, the acceptable range for that is 90 to 140 for systolic, and then the letter D for diastolic is 60 to 90. Those are the numbers you want to remember for this test. I know they may be somewhat different than what you're told in school or maybe at your facility, but these are the numbers that they're going to be, that we find. If you know these numbers in this range, you kind of pretty much can get the question correct. All right, so I am at a point where I'm ready to take a break, and I think we'll probably go ahead and do our little 30-minute lunch break at this point in time. So before we break, let me check in with Tom. Tom, are you with us?
Yes, I'm still here.
You're still there. Okay. Is there any thing that I need to address before we take a little 30-minute lunch break?
No, nothing that I can see.
Okay. All right. So everybody must be doing good then. So we'll go ahead and break for lunch, and we'll come back at the top of the hour, which would be, 2 p.m. Eastern daylight savings time. Okay. So the top of the hour is when we'll come back, right at 2 o'clock. Everybody have a good lunch. We'll see you then.